I'm going to briefly introduce each one of you. I'm going to start with Dr. Semrad, who is a GI specialist for small bowel disease at the University of Chicago. Dr. Sukhmani Padda is a thoracic oncologist at Cedars-Sinai. Dr. Erik Mittra is a nuclear medicine specialist at OHSU. Dr. Osmanuddin Ahmed is an interventional radiologist at the University of Chicago. Dr. Thor Halfdanarson is a neuroendocrine tumor oncologist at Mayo Clinic, and Dr. Liao is also a neuroendocrine tumor oncologist at the University of Chicago. So welcome to all of you. I'm really excited to have you here today. We've had quite a bit of questions that were asked. So we had over 45 questions, and obviously we only have about 20 minutes to do this. So I've selected some of those questions out. I'm going to start right up front with, like I said before, being a little selfish and asking myself a question, which is, as the only surgeon here on the panel, which is, or was, do neuroendocrine tumors increase after surgery? And I think it's important for all of our patients to know that there's absolutely no data to suggest this. It's not the first time that we've heard this, that like patients are concerned that if you do surgery, you spread the tumor, or if you do interventional procedures that Oz does, for example, that you could spread tumor cells and that your tumor would progress. There's absolutely no data suggested that that is actually a real phenomenon. So I think it's really important to mention that to our patients. Now, let's move ahead to the next question, which is sort of directly and like indirectly related to surgery, but also I think in a larger audience to the neuroendocrine tumor patients. So there was a study that was presented at NANETS this year that showed the safety of managing neuroendocrine tumor with like carcinogenic symptoms in the operating room without any octreotide. So I could tell you that at the University of Chicago, as long as you're on long-acting octreotide, we don't give additional octreotide during surgery. But I would be curious to see Thor, for example, how if somebody has a dentist appointment or a procedure that they need to undergo, and they ask you, they call you the night before, they're like, oh my God, I completely forgot, but should I be on octreotide? Should an octreotide drip be run during these procedures? What do you tell them?
So what I tell them, it's a great question. So I tell them that typically if you're on a long-acting octreotide injection monthly or every 3 weeks, it's probably not needed. And I think the risk of carcinoid crisis triggered by especially minor procedures is very, very, very low. So I think most patients will not need any additional octreotide. And for patients who have neuroendocrine tumors and are not on somatostatin analogs and don't have carcinoid syndrome, I think the risk is very, very low as well. So I think for the vast majority of people, we don't need it.
Fantastic. Thank you, Thor. Let's move on to the next question. This is something for Dr. Ahmed. So if embolization was done up an initial diagnosis, can this procedure be repeated throughout my NET journey?
Yeah, Xavier, great question. Frequently asked this as well. The short answer is yes. You can, frequently undergo multiple interventional procedures, and really what we're guided by in terms of our ability to do a second or a repeat intervention is specifically how healthy are you as a person, meaning are you able to carry out your normal daily activities? You're not bedbound, things like that. You're doing okay. And then specifically, because most of our procedures are specifically in the liver, particularly embolization, we want to make sure your liver is healthy as well. So as long as your lab values suggest that your liver is still doing well, which more often than not it is, you are frequently a candidate for a repeat procedure.
Fantastic. Thank you so much, Oz. We'll move to Andy. So one of the patients was asking, does octreotide lose efficacy over time?
Yeah, that's a good question. So we use octreotide mainly for two reasons. One is to control symptoms related to hormonal overproduction, so carcinoid syndrome. But the other is that, octreotide can actually slow down the tumor growth. And like other treatments that we have for NETs, each treatment tends to be effective for a given amount of time, and that varies, can vary widely from patient to patient. For one patient, octreotide may hold the tumor in check for many, many years and even longer than that. But then for others, it may only do so for months. And we know that, tumors definitely change and evolve over time during the treatment. And that may perhaps be, why octreotide may lose its efficacy eventually.
Great. Are there certain specific subtype of tumors that respond better or longer like to octreotide? And I'm going to actually let you answer a question, and I'm going to ask the same question to Suki about lung nets. What is the data for long-acting octreotide and lung nets?
Yeah, so generally, these patients who respond better to octreotide, their tumors generally have, they're well differentiated or moderately differentiated, lower grade tumors, and that they express a lot of the somatostatin receptor, which is what the drug binds to.
Thank you, Andy. And Suki, what do you think in terms of long-acting octreotide and lung nets?
That's a great question, specifically for our patients with lung nets, because we don't have the same high-level data that we do in patients with GEP nets as it relates to octreotide or lanreotide. Although Dr. Reedy at the NANET Symposium this year did present the analysis from the ambitious SPINET trial, which was initially planned as a randomized study of lanreotide versus placebo, but they had a lot of difficulty with accruing patients to that study. So then they had an expansion arm of patients who received lanreotide without randomization. And there we did see that there was evidence of prolonged progression-free survival in patients with lung nets, including typical carcinoids and atypical carcinoids, although that the benefit may be more robust in patients with typical carcinoids, which also speaks to, I think, the biology of the differences between typical and atypical carcinoid. So it's definitely a treatment option for our patients with lung nets.
Thank you so much, Suki. All right, I think the next question will go to Dr. Halfdanarson. Thor, one patient was wondering if there's any benefit of a continuous infusion of octreotide versus octreotide every 14 days. And I think we have to mention that traditionally octreotide or long-acting octreotide is given every 28 days. So I'm assuming the question also relates to the fact that like that particular patient has been prescribed octreotide on a shorter interval, whether it's for tumor control or for symptom control.
So great question. So for continuous infusion octreotide, I think it might, in extremely rare cases, be useful if you have a completely uncontrollable carcinoid syndrome. But keep in mind that often you can do something regionally with embolization or with surgery to reduce the production of serotonin and other chemicals. So when I was at the University of Iowa, this was used fairly frequently. I left there 8 years ago. I have not once used a continuous infusion octreotide since then. I will also say that we now have data on lanreotide every 2 weeks from the Clarinet Forte trial, which was a small trial that looked at the patients who progressed or had progressive disease on conventional dose lanreotide, and they were given lanreotide every 2 weeks instead of every 4 weeks. As I recall, it didn't really look much at symptom control, but the tumor control, there was definitely a signal of this being modestly active. But to answer the question, typically not much role for continuous infusion of octreotide.
Thank you so much, Thor. All right, let's move on to the PRT chapter, so to speak. Plenty of questions on that thematic. So the first question is going to go to you, Erik, if you don't mind answering, what percentage of people gain stability after PRT, and why doesn't it work for every patient who gets it?
Yeah, great question, and it's a very difficult one to answer. I think it really gets to the heterogeneity of neuroendocrine tumors, which we all know about. So if you look at the data from the NETR-1 trial, which was specific to patients with gastroenteropancreatic neuroendocrine tumors, specifically midgut, most patients, the majority of patients did have a response, but even then the duration is different depending on each of the patients. Then if you look at all the different subtypes of neuroendocrine tumor and the origin, the grade, the distribution of the disease, the degree of somatostatin receptor expression, there's a tremendous number of reasons. It's quite effective, but not for everyone.
Why don't we go to Suki? What do you think? Let's talk about lung nets and PRT. Has that been something that's been used, and does it work well?
Yes, so PRT has definitely been used in lung nets, but again, not studied in the same sort of robust way that we have from the NETR-1 study for patients with gastrointestinal nets. So what we know from single institution or multi-institution cohort studies is that a subgroup of patients with lung nets will respond. Response rates have been described somewhere between 10 to 30%. Time to progression has been described anywhere from 10 to 30 months. So we really need high-level data to guide this treatment for patients with lung nets, and also how to sequence amongst our other treatments. So Tom Hope, who's a nuclear medicine physician at UCSF, and myself are leading a clinical trial through Alliance and also in collaboration with ECOG Akron that are trying to definitively answer what is the role of PRT in patients with lung nets. So this study was just activated in September, includes patients with typical and atypical carcinoids. We're going to be examining the somatostatin receptor positivity for selection onto study. And then there's a randomization to standard dose lutetium-177 dotatate versus the current standard of care everolimus. And it's important to note that even if patients are randomized to the everolimus arm, they would be eligible for crossover at the time of progression, or at least assessment for crossover to the lutetium arm.
Great. Thank you, Suki. And we're looking forward to see that data. All right, let's move on to Dr. Semrad. So that's a question that's sort of a challenging one, I think, which is a lot of the challenges that I'm sure you see with neuroendocrine tumor patients and GI symptoms. That particular patient says, I have constant severe gas and bloating, possibly from a tiny net, causing nerve damage and fluid buildup. Has anyone had this problem in patients? So I think this also comes down, Dr. Semrad, to the point, how do we really differentiate what is net related and what's not? And what is the role that you can offer patients to try to help them?
So first of all, gas bloating is a very common symptom, so it's hard to pinpoint that into a certain process related to NET, but a few ideas here. First of all, I'm not aware that small nets damage nerves. If you have significant tumor burden of the mesentery or the peritoneal cavity, the bowel has to constantly move to digest and absorb properly, and it can get locked into position so that it just can't do its to and fro motion and absorb properly. And that, once we start malabsorbing nutrients, they go to the colon, and then of course gas and bloating is created. The other is, I'm not sure about this individual patient, but octreotide. So octreotide, let's just talk about carcinoid and NET or carcinoid syndrome. The mechanism of diarrhea in carcinoid syndrome is hypermotility of the bowel. And so their high-dose octreotide can block that effect. But in people who might be taking it to prevent tumor progression they might get paralyzed bowel from these high doses, and that can lead to small bowel bacterial overgrowth. So again, you have to take it in context of who this individual is and what was done. And lastly, clearly surgeries, whether they be pancreatic or small bowel resections, can lead to the gas bloating, a number of mechanisms there as well. So I think the most important thing is the specific history of this patient and trying to sort out what's the contributing factor to these symptoms.
Thank you so much. And I think you bring up a really good point, is try to figure out what is causing certain things, right? We have a lot of like neuroendocrine tumor patients that have had all kinds of therapies,
yes,
or no therapy, or just a history of a neuroendocrine tumor that was resected. And sometimes things are related to like neuroendocrine tumor disease, but sometimes they aren't, and there's something else going on. And I think what we are really like excited to have at the University of Chicago is somebody like you, and I'm sure you all have that in your institution, that specializes in small bowel like disease and really trying to understand and sort out. And it can be, I'm sure, sometimes a really long process that can take some time to try to figure out what exactly is causing the symptoms.
It is, but his history is everything, and then sort of a systematic approach to the symptoms, what makes it better or worse. It's really kind of an art more than a science, if you will. In NET type patients, they just have a lot of possibilities.
Right. Perfect. Thank you so much. Erik, another question for you. Thoughts on alpha PRRT? We hear it over and over again. All our patients walk into our offices. I'm sure Andy, Thor, you've all heard, Suki probably, you've all heard about it. Can you talk to us a little bit about alpha PRRT? It's a hot subject, but is that about to hit the market, or how good is it? Is it better than the standard PRRT? What are your thoughts?
Yeah, sure. Yeah, alpha PRRT, we're all very excited about it. It's basically a larger molecule which can cause more damage to the cells, and it's in clinical trials right now. So we're still a few years away from it, but all the data does look very promising, I would say. Also, it has very low toxicity, which is important for patients who are being treated multiple times.
So let's do one more question. Andy, is it true that everolimus should not be used with someone that has carcinoid syndrome? And maybe Thor can weigh in there as well as the last question for the session.
Yeah, that's a good question. So, it's not that everolimus is contraindicated or harmful in NET patients with carcinoid syndrome. I think what you're referring to is many years ago, there was this trial called the RADIANT-2 study. So this was a phase 3 clinical trial looking at everolimus plus octreotide LAR versus placebo plus octreotide LAR in patients who have advanced NETs with carcinoid syndrome. And the primary endpoint for that study was progression-free survival. So, the time that the treatment keeps the tumor stable for. And numerically, there was an improvement in the everolimus arm. I think there was like a 5-month difference between the two arms in terms of improvement in progression-free survival. But statistically, it did not meet statistical significance. So I think that's where this question is coming from. But, you have to keep in mind that, there is definitely a numerical improvement, and, patients are not statistics, they're not numbers. And, just because it is not statistically significant doesn't mean there can't be a clinically meaningful improvement.
Great, thank you. And actually, I just got noticed that we have time for one more. So, Thor, I think I'll have you answer that one if that's okay. One patient's asking, does higher SUV uptake on the gallium or the copper dotatate equate to better and longer response to octreotide therapy?
So great question, and I have not seen really conclusive data, but the brighter the uptake there is, presumably the more receptors are on the surface of the tumor cell. So yes, it would make sense that we would see a longer tumor control and really brighter tumors, but it hasn't really been conclusively shown. I'd like to ask Erik if he's heard any data on that.
I would say that, it's certainly a certain cutoff is important. So when we commonly use the Krenning score for uptake on scans, and so it does have to be above a certain level. But you're right that beyond that certain level, then we don't have great data on if it continues to be a linear relationship or it sort of drops off after time.
It actually should be fairly easy to study. Maybe an idea for a sort of.
Maybe we should all get together and study it.
Mm-hmm.
There we go. You see, these calls are very useful. Our patients always like push us to study the questions that they want answers to, that sometimes we may forget or like overlook, or we think it's not that important, but clearly this is a great question.
Mm-hmm.
We learn from our patients every day, I guess, right? So that's a really important message here. I really appreciate all of your time today, especially on a weekend. It's a beautiful day in Chicago for once. It was really great to, spend this time with you. Thank you to all of you to also take the time to record your talks. I think they really were phenomenal. I'm sure they'll be really helpful to our patients in the future. So with that, thank you very much. And I hope to see you guys soon. And I will hand this back to Rich at this point. Thank you.